So Adam is the Director of Cardiac Sciences at the Royal Brisbane and Women's Hospital. He has a PhD in cardiac medicine from the University of London, Imperial College in the UK. Adam is widely published in the areas of exercise physiology and skeletal muscle physiology and chronic heart failure. He is a Fellow of the Cardiac Society of Australia and New Zealand, the European Society of Cardiology, the American College of Cardiology. You got enough stuff there, mate? And Exercise and Sports Science Australia. So Adam is an adjunct professor at QUT and is the founder and chairman of the White Cloud Foundation. Please welcome Adam.
Perfect, thank you. Well, thank you very much for having me here today. I feel very privileged to be presenting and a little daunted having just seen the Higher Up platform and how impressive that is, and just think we were discussing down the front, Queensland Health can learn a lot from this level of innovation, and unfortunately my presentation's nowhere near as slick or as entertaining, so I apologise very early on. I'm very passionate about creating early access to treatment in local areas. So I have had a number of friends living in rural communities. One particular 46-year-old friend who is an identical twin living in a Northern Territory cattle property, and 46 years of age, had been having chest pain rounding up the cattle and hadn't done anything because it was just too hard to go and get an investigation or a treatment or see a doctor. And unfortunately, he'd been rounding up the cattle, got some chest pain. His twin brother went and racked the horses, came back, and his brother's on the ground, did CPR on him for 2 hours, and he died. He was 46 years of age. And so his brother came to me and said, could something have been done if we'd had known about this? And I said, oh my gosh, yes. If you'd been living in the city, it would have been treated straight away. And that's where I'm very passionate about getting access to treatment anywhere, regardless of your geographical location. So I've worked really hard in trying to think of innovative and different ways of doing this. So when we talk about, I'll take you on a bit of a journey here. When we talk about cardiovascular disease, it's the #1 cause of death globally. On average, 1 Australian dies from heart disease every 27 minutes, and it's the leading cause of death for both men and women in Queensland. Remote areas of Queensland have statistically higher rates of mortality from coronary heart disease than the state average by about 25%, which is really concerning. And the reasons behind this are based around reduced access to primary healthcare programs for early detection and treatment of people with risk factors compared to metropolitan locations. This results in less effective and equitable healthcare services, with many people in the country being detected late in the course of the disease and dying young. And this is just not fair. So, I'm a big believer in working collaborative together. So, how can we unite clans from various disciplines, various hospitals, and break down these silos so that we can get the right treatment for the right people at the right time? So when we look for solutions, what can we do to address this problem of heart disease in Australia? How can we create that local access to treatment for patients? So 10 years ago, I looked at, when I first started at the Royal Brisbane, how we could create better access for patients that were in chest pain. So they were coming into the hospital through emergency, and they were being put in a bed, and there they would wait for 1 day, 2 days, 3 days, 4 days. And so we implemented a chest pain pathway that would enable patients to have rapid access to stress testing to rule out that they had coronary artery disease so that they could be discharged rapidly. And that has seen immense success in overnight bed stays within the Royal Brisbane and Women's Hospital. From that, we learned a raft of different things, such as, do we need to stress test patients under 40 years of age? And we did a retrospective study looking at this, and we found that routine stress testing on people under 40 years of age has limited productivity in producing and assessing for coronary artery disease. Then we started looking at how can we create access to stress testing for locations that don't have a cardiology department. So they might have no cardiac investigations, they might have a nurse, they might have an ECG machine. How can we do things differently from the normal metropolitan locations? So we started looking at utilising non-physician-led stress testing. This is where there's no doctor in the room. A doctor screens the patient, but to have a doctor standing by a treadmill for an hour watching a stress test when you've got these health professionals that can be trained up to do their tests seemed really silly to me, and they could be better off discharging patients and triaging other patients. So we implemented two different models, one at the Royal Brisbane using an inpatient model to look at how we could create this very slick, efficient service for inpatients, and we also implemented an outpatient model at Logan. And this has created patient flow improvements with earlier discharge, reduced waiting times, and the key one is timely identification of possible cardiac pathologies, thereby creating a rapid access pathway to further treatment rather than days delayed for treatment. So we took this on the road. So we piggybacked onto the back of the ACRE project, which is the chest pain pathway process, which has been tidied up, slickened, and is very effective now, where the ACRE team would go out and identify staff that could be trained up in stress testing. So generally we identify 2 nurses from each site. They'd come down to the Royal Brisbane, and we would spend a week and we would do comprehensive ECG training, we would do exercise stress testing, stress echo, nuclear medicine stress testing, to be able to provide them with high volumes of stress testing to bring them up to speed so that they could understand and see a wide variety of patients and what they can do during that process. And that has worked really well. But the key things that we've identified in reality is, how can we provide greater access to diagnostic quality cardiac investigations? How can we improve everyday practice of stress testing and ECG interpretation? Because in wider rural remote communities where someone might be a jack of all trades, you can't be an expert at everything. And so how can we utilise our knowledge in a metropolitan location and our resources and our expertise to be able to support those locations that don't have that? So this is where we came up with a tele-stress testing. In this we call it tele-super educating because it was supervision and education during stress testing. So it's morphed into a raft of different things. And this, excuse the quality of this was done on an iPhone in about 40 minutes at the Royal Brisbane in cardiology there. So can we play that video now, thanks?
Cardiovascular disease is the #1 cause of death globally. On average, 1 Australian dies as a result of cardiovascular disease every 12 minutes. Remote areas of Queensland have statistically higher rates of mortality from coronary heart disease than the state average by about 25%. There are many reasons behind this statistic, including reduced access to primary healthcare programs for early detection and treatment of people with risk factors compared to metropolitan locations. This results in less effective and equitable healthcare services which respond to their needs. As a result, many people in the country are detected late in the course of the disease and die younger. This is Barry. Barry's recently had some chest pain. His GP referred him to Longreach Hospital for an exercise stress test. In the past, Longreach Hospital were only able to perform stress tests 1 day per month due to limited access to medical supervision or qualified staff to perform the test. This means that it will potentially be up to 3 months before Barry can have a stress test to assess the severity of his chest pain. Barry could die before he gets his test done. Is it fair that Queenslanders living in rural locations are unable to access the same level of healthcare as people living in metropolitan areas? Can we use telehealth to solve this problem? In the past, telehealth has been clunky and unsophisticated. Nowadays, we have slick network access and high-quality equipment with teams of telehealth people that can put clinicians and patients together.
To better support our clinical colleagues in Longreach, we've developed Tele-Super Educating to achieve diagnostic quality exercise stress test results. With the low number of tests performed each month in Longreach, we found that staff were de-skilling, resulting in early cessation of the exercise stress test. This meant that the patient did not receive a diagnostic result and would often have to travel to the tertiary hospital in a metropolitan location to repeat the test. This obviously increases waiting times, costs of travel, and delayed treatment if the patient has a positive test result for coronary heart disease. Now, we have a cardiac scientist at the Royal Brisbane and Women's Hospital supervising and educating the staff in Longreach via real-time telehealth during the exercise stress test.
So Emma, can you just check those ST segments inferiorly? Let's pop over to Longreach and check out their end of the service.
The RBWH and Longreach Hospital utilise trolley-based video conference units that can pan, tilt and 12 times zoom a camera, which is remotely controlled by the RBWH clinicians to get the best angle of the patient on the treadmill or bed. It can also be used to zoom in on the operator console to provide remote assistance in the operation of the stress test. Another important feature is the ability to directly connect into the stress testing unit to send a direct live image of the ECG, allowing the clinicians at the RBWH to have two screens set up, one with a live image of the patient and the other with a live image of the ECG. Two-wave audio is provided via high-quality microphones at both ends and allows the clinicians to provide instructions in real time.
What this means is that Barry can now get access to greater availability of exercise stress testing, and the staff can get the supervision and education to maintain their skill base to confidently perform and achieve diagnostic quality results. Patients now don't have long wait lists for this test. They also avoid having to travel long distances to metropolitan centres for this investigation. Barry did have significant coronary disease, but now he can be treated to reduce his risk of suffering from a heart attack. This makes Barry and his rural community happy.
So can I just say, there is no way we would have been able to do any of this without this fantastic team of individuals from Telehealth, from cardiology at Royal Brisbane and from Longreach. So we're very aware that it requires clinical champions to be open and eager to be able to implement these sort of innovative models. So I'm really proud of my team. They are an awesome group of people, and without them, we would be nowhere. So I give them huge respect and thank them at every opportunity that I can. So we implemented this tele-stress testing service with Longreach in February of this year. And so what we've seen so far is we've got the staff there, and there is a rotation of staff going through because obviously it's a rural location, so it requires constant upskilling and educating of staff. So we've got increased education. However, the key difference is now the diagnostic quality of stress testing. So previously, there tended to be a lot of submaximal or results or reporting which wasn't quite as accurate, whereas now it's very accurate. They're all diagnostic quality tests. The patients, when they want to stop and they think they're at 85% of heart rate and they're actually at 75, we're able to encourage them to keep going and get that diagnostic quality result. We've also been able to reduce the wait time for patients to be able to access a testing procedure. And we believe we can get that and fine-tune that even further, so down to, I'm hoping, a same-day service, but I'm always very optimistic and eager. The reporting time is another big one. Previously, the stress test would get printed out, sent in the mail to a tertiary hospital, where it would sit on a consultant's desk waiting to be reported. Then it would be reported, sent back in the mail. So it could be up to 3 months before getting the actual report of that stress test from that simple procedure. And so what we've developed now is that stress test, as soon as it's completed, gets emailed directly to our team. We print it out. We report it, we take it to an advanced trainee cardiology registrar who reviews it, signs it off, we scan it and send it back to them immediately so that they've got the report within an hour of doing the stress test, which is they can then make greater decisions in how they treat those patients. We've also seen a reduction in travel time to repeat the test. So those patients that weren't getting diagnostic quality tests may have to have been referred to another tertiary hospital in the state, which involves huge costs in transport and travel. So we're able to reduce that amount of travel time by getting the right test done at the right time in the correct way. The best part of this program, I believe, is that when we do identify someone with a positive test and they have got coronary artery disease, previously they would go to Rockhampton for further investigation, which would show that they have positive tests. They'd come back to Longreach, and then they'd get sent back to Brisbane to have an angiogram. Now what we've identified with that positive test result, we're bearing on the patient's time frame, we can get them down to Brisbane at the Royal Brisbane, and in 2 days we can do comprehensive CTCA, stress echo, a clinic appointment with a cardiologist. They overnight, and the next day they get an angiogram if required, or they go home. So that way they get all of that testing done within 2 days rather than having one-off tests flying back each time until they get treated. So we believe that's a really nice, slick pathway, and the way that we can create it is by talking and communicating and asking ourselves, how can we help these rural communities, rather than looking at our silo and just thinking, how can we make our silo bigger and better and stronger? I'm all about creating that access to those rural locations. So the future, where do we go? So my vision is always big. I'm always planning to do bigger, better and further. So it's to expand the service, to be able to provide contemporary specialist services to rural and remote areas. So to take our cardiology expertise to locations that don't have it. To be able to support reduction in wait times and costs associated with patient travel and repeat testing. So we recently were very lucky to receive $1.5 million over 3 years by the Health Minister. And that's to be able to support a greater number of sites, and so I've got them listed there, so 11 rural and regional hospitals to do stress testing at. However, these funds don't go far. That covers 2 cardiac scientists, a registrar and an admin officer to be working full-time doing stress testing on within all of those sites. But what we're aiming with that is that at any time, 8 to 5, Monday to Friday, any one of those sites can do a stress test. So in the same time, we'll also be providing education and support services to them so that they're going to be thinking more around not just, hey, we can do this with stress testing, what else can we do it with? So there's always an extra set of steak knives. So on top of that funding, what I said was not only we will do stress testing, but we're going to be now open up to the whole of the state that don't have access to 24-hour Holter monitoring. So for those that don't know about Holter monitors, a Holter monitor is when patients get palpitations, chest pain, shortness of breath, skip beats, dizziness, lightheadedness or syncopal episodes, and it's of cardiac origin, a Holter monitor is put on and we attach a number of different electrodes and it records the electrical activity of the heart for 24 or 48 hours. So what this does is it enables us to be able to see what's going on with their heart, why they're getting those dizzy episodes, do they need a pacemaker, do they need a defibrillator? And currently in those regions that don't have access to this, it's a long wait at a tertiary hospital just to get in line to be able to access those. So the issue that we see currently is reduced access. So we have long waiting lists or large travel distances for patients currently to be able to access that from a tertiary location. This leads to patients, such as my friend in the Northern Territory, not going for investigation or delaying treatment, which leaves cardiac arrhythmias, especially with Holters going undetected, being very, very dangerous because you could be getting rapid heart rhythms which could be fatal, which can go completely undetected. So now we have this capability to be able to get these Holter monitors out there, get them onto patients, and we'll talk about how we'll do that in a minute. But basically, this will result in reduced volumes performed by those locations that are currently doing it and de-skilling of staff and decreased accuracy. So to analyse a 24-hour Holter monitor, you've got to be, we spend a lot of time, students spend 4 years at university, they do a comprehensive 12-week ECG course, they then do 400 hours of prac placement full-time just to be able to do an ECG, a stress test and a Holter. So that when they finish on a Friday, they can start anywhere in the world on a Monday working as a base grade cardiac scientist. Now, once they get that role, they still have to undergo a year of supervision, and every single Holter monitor they report gets heavily scrutinised by a senior cardiac scientist, so that the quality of the investigation that we provide is of very, very high standard. I'm very proud of our unit and the quality that we provide because there are a lot of groups out there where the quality is not there and it's just the volume and it's based around revenue. So now our solution that we're implementing is where any site anywhere in Queensland or Australia can get access to a Holter monitor. They put it on the patient. 24 hours later, they take the Holter monitor off, they plug it into a computer, and it downloads all that information to our server and pops up on our work list at the Royal Brisbane. One of our cardiac scientists will immediately analyse that result. A cardiology advanced trainee registrar will report it, will sign off that report, and if need be, we'll escalate it to a consultant, and if need be, we'll then get that patient in immediately. Otherwise, that result can then be sent directly back to the requesting doctor, GP, local health provider, local hospital as required. So what we're trying to do is create that access, get that high quality testing, but also get those numbers, figures, results, reports back to the right people who need to see them so that they can make better decisions in how they treat their patients. So what does this mean for patients? Patients now will have, in Queensland, rurally and remotely and regionally, improved access to local cardiac investigations. This will result in early identification of serious arrhythmias or cardiac conditions, improved diagnostic quality of tests and accurate reporting of results, and decreased costs to patients and the health system. All results will be sent to obviously all of the local health teams. And the big one, and I haven't spoken to my team about this one yet, but I have a solution for echocardiography. And this is a big one, but you're going to have to wait for that one, so I apologise. I can't release that today. Just, oh, yeah, it's going to cost you. So the beauty of this program is we started this with nothing, no funds. We had a great telehealth team that got the resources, the cameras, the equipment, and set them up. And I sit there at my desk while I'm trying to direct my department, and I do the stress test with Longreach, because I recognise if I don't do it, no one else is going to do it. So we did this with no funds and very minimal resources, and that's the sacrifices we've got to make to be able to get it in front of the Health Minister and show the runs on the board and the innovation and the effectiveness to take it to that next step. So my plan is basically to take cardiac investigations to the whole state and provide it innovatively, look at it, evolve, progress, communicate. This is not, the silo I see we're working in is Australia. We are one family or we are one community, and that should be the only silo. There should be no little silos within silos in that whole process. So I'd be more than happy to take any questions. I'll finish 7 minutes early. It's nice and efficient. Yeah, if there are any questions, I'd be happy to.
I've got one. Hello.
Hi.
Thanks for that. With the results, do you think about sending them to the patient as well so the patient can follow up with their treating team?
If you'd like that, we can make that happen. We can do anything. Yeah, we just need to hear what people want, and then it's a matter of going, okay, if you'd like that and we can do it, let's do it. I must have answered everyone's questions. Well, thank you very much. I've really appreciated being here today. I'm going to be here until afternoon tea. Happy to answer any questions there.